A male patient presents with pain in his amputation stump. I am showing you the radiographs of the stump. Describe the findings.
Okay, I see it. The radiographs demonstrate a previous below-knee amputation with osteotomies of the tibia and fibula. There is a permeative lucent lesion with a wide zone of transition affecting the distal tibial stump. The lesion has poorly defined borders and merges imperceptibly with the surrounding normal cortex. A linear periosteal reaction is visible along the posterior tibial cortex, and a similar subtle reaction is noted along the fibula. Faint, subtle lucencies are also suspected along the anterior cortex of the distal femur. These features are consistent with an aggressive, rapid bone-destroying process.
What is the differential diagnosis for this permeative stump lesion, and how do you narrow it down?
The differential diagnosis for a permeative bone lesion includes osteomyelitis, metastases, lymphoma, leukemia, and myeloma. To narrow it down, the clinical history and the reason for the original amputation are of paramount importance. If the amputation was for trauma or peripheral vascular disease, osteomyelitis is a very likely diagnosis. However, if the amputation was performed for a primary bone malignancy, local recurrence is the leading diagnosis. The presence of suspected synchronous lesions in the distal femur without joint space narrowing strongly points towards a systemic malignancy like lymphoma.
I'm showing you two comparison images, a tibia plain film and a coronal fat-saturated MRI. Describe their findings.
The first image shows anteroposterior and lateral tibia radiographs demonstrating a permeative bone lesion with extensive cortical destruction. The second image is a fat-saturated coronal MRI from the same patient, illustrating a highly aggressive, hyper-intense tibial lesion. The MRI clearly shows a wide zone of transition, permeative bone destruction, and cortical breach into the adjacent soft tissues. This highlights how MRI is far more sensitive in identifying early marrow replacement and soft tissue extension.
Describe the radiological characteristics of aggressive versus benign bone lesions.
In that case, aggressive bone lesions, such as malignancies or active infection, typically demonstrate a wide zone of transition and poorly defined borders. They also show permeative bone destruction, cortical breakthrough, and complex periosteal reactions like lamellated or sunburst patterns. In contrast, benign bone lesions show a narrow zone of transition, well-defined geographic margins, intact cortex, and absent or thick benign periosteal reaction. However, infection is a great mimic and can present with highly aggressive features resembling a primary sarcoma.
Discuss the management, role of tissue sampling, and how you would manage this patient as a radiologist.
Well, further clinical management requires staging with CT of the chest, abdomen, and pelvis, along with a PET CT. An MRI of the stump is essential to define the local tumor extent and plan any subsequent surgical revision or radiotherapy. A biopsy, typically ultrasound or CT-guided, is mandatory to establish a histopathological diagnosis prior to systemic therapy. As a radiologist, I would recommend staging imaging, suggest staging referral, and coordinate a biopsy after discussion in the multidisciplinary team meeting.